very much. Disclosures. What I'd like to do is to talk about the epidemiology of Hep C in British Columbia, talk about our local baby boomers, and talk about people who inject drugs in our province. Discuss the potential impact of virological curability, or SVR, on health and transmission outcomes, as has been alluded to, and suggest that hepatitis C treatment as prevention will need to be part of a comprehensive population-based prevention care and treatment strategy. So in this figure, in our province, we have a very centralized testing system at the BC Centre for Disease Control, and we have tested, as of March 19th, 1.2 million people. That's about a quarter of our population. Of those, 72,000 were positive as of March, and a bit shameful, 8,000 were seroconverters since 1992. And what you see here is the rate per 100,000, and in dark gray you see a very large peak around 95, 96, 97, which reflects increased testing largely due to look back and trace backs for blood system contamination. You can see that there's a decline in the rate, and in black is the rate in Canada. There's more injection drug use that takes place in British Columbia. In the light gray, what you see is a process that we do nightly. We have an automatic reconciliation identifying seroconverters, and in this case we've used a 24-month window of seroconversion. So these are people who've been tested frequently, and you can see that the rate of seroconversion, these are truly incident cases, has been declining. What we've also done is looked at the age distribution of reactive hepatitis C testers, and despite consistent testing over all of the age strata, in fact more testing in the young, what you see here is the percent antibody positive from cohorts from 92 to 95, 96 to 2000, 2001 to 2005, 2006 to 2011. And what you see is over time, the median age has gone from around mid-30s in 92 to 96 to approximately the mid-50s for 2006, 2011, which is very compatible with the data you were shown from the US in baby boomers. So this is the group that's an aging cohort needing screening, triage, and treatment, and not often involved in ongoing risk activities. What we've done is looked at our baby boomer population. As of our BC census in 2011, we had about 4.4 million population. Of those, about 31% or 1.3 million were baby boomers. And the percentage of our population as of the date listed that we had tested was 23%, or about 1 million people. And of the those that were baby boomers were just around 350,000, or 26% of the population. Our baby boomers represent 3% of all of our positives versus 1.4% in the general population, and they represent 64% of all of our positives. In terms of the unscreened population, 1 million people in British Columbia remain unscreened, and while we don't know what the prevalence in that population, given that this testing was risk-based, we could assume that it's somewhere between 15,000 to 30,000. That would give us about 55 to 70,000 antibody positives, and since approximately 25% will clear, there's about 44 to 56,000 people who are RNA positive. The travesty, of course, is that in identifying seroconverters, we've been collaborating with our federal national laboratory and doing enhanced surveillance. And since 2000, essentially 81% of the people we identify as seroconverters are people who inject drugs ever. Sadly, 38% report previous incarceration, as you can expect. But the fact of the matter is correctional facilities are not a good place to deal with addictions and mental health. And nationally, the incidence in Aboriginal populations or First Nations is 14 per 100,000 versus 2.2 in non-Aboriginal population, which is again a travesty on how we manage our First Nations populations. In having this data, we were able to link anonymously our laboratory data to the population administrative data sets. And we published a paper in collaboration with Marie Cron in 2010, where we essentially assigned subjects to 3 observation times, 12 months prior to death, a late phase where they had a diagnosis administratively of decompensated cirrhosis, variceal bleeding, ascites, encephalopathy, liver cancer, or transplant, and then an initial phase where all they were diagnosed, but they had no administrative codes of end-stage disease. And then what we did was we matched cases and controls. So the controls were hepatitis C tested, but negative versus positives. And we tried to identify any cost, direct cost assumed by the government in British Columbia. We had one case for every 4 matched, approximately, and there were 4,800 controls who were pre-death, 1,600 cases, and you can see that death from any cause in British Columbia is an expensive proposition. But although we propensity matched these people, they died at a younger age, about 5 years younger. When you look at late phase controls versus cases, the costs were about twice as much. There were 1,000 cases and almost 4,000 controls. Their costs are 2 times higher, but they represent a small proportion of person years overall. The largest group was 62,000 controls, where all they had was a diagnosis, and there were 18,000 cases, and again the costs were twice as high. This represents the most person years. Mental health, addictions, HIV were very important cost contributors. So Hep C infection is not the major driver at this point in their lives. And we estimated our provincial spending at $136 million per year in 2005 dollars, and this has to be contrast with what the costs will be to treat these individuals. What we also did is we looked at a large data set of 350,000 people who were Hep C tested and negative, 29,000 who are Hep C positive, and about 2,500 seroconverters. This has been recently published by our team. And as you all know, acute hepatitis C rarely results in death. So if you detect mortality in a recent seroconverter, in fact, most of these seroconverters had seroconverted within 5 years, it helps you tease apart the impact of risk activities related to hepatitis C acquisition from the mortality related to chronic infection. So I know that this is a very busy slide, and essentially this is standardized mortality ratios. If you die at the rate of the general population, it's 1. If you die at twice the rate, it's 2. If you die at half the rate, it's 0.5. And we, by illustration, have data from Australia, Sweden, and Scotland, but in yellow, and I guess that's green, some of the data from our province. If you're hepatitis C reactive, you have almost a 5 times higher mortality, and your liver-related mortality is 23 or 24 times the general population, and your drug-related mortality is 21 times the general population. If you're a first-time reactive test, it means you don't know whether they're a seroconverter, it's their first test, or they're a chronic disease. Most of these are chronic disease. The numbers are the same. But for those seroconverters, most of whom were diagnosed within the last 5 years, their mortality was 10 times higher than the general population of those who are antibody negative. They had less risk of liver disease, and their drug-related mortality was 37 times higher. To summarize the Hep C disease burden, and you've had other points from John and Ron, in terms of the baby boomers, there's a limited onward transmission, but these are the people at risk of progressive liver disease and all-cause mortality, and virological cures, you've heard, will soon approach 90%. For people who, in inject drugs, these are the source of our future challenges, onward transmissions, and hepatitis C is a surrogate for risk. Early mortality reflects risk activities, and we're going to need a multifaceted approach of testing, seeking, harm reduction, retention and care, with particular attention to mental health and addictions, as well as treatment as prevention. This figure looks at the data from Vandermeer, largely in people who were chronically infected, and the implications of a sustained virological response, which is measured either 12 weeks or 24 weeks after you've stopped all of your therapy. You can see that from all-cause mortality, if you have an SVR, you do better. If you don't have an SVR, you do worse from a hepatocellular carcinoma perspective, from a liver-related mortality and liver transplant perspective, and from a liver failure perspective. It doesn't totally reduce your total risk. It's like smoking. So you stop smoking, you still have a risk. You still have to follow up these patients because they have ongoing risks. You've heard that we're going from these injectable, intolerable drugs, which are interferon-based, that make you feel like you have the flu for 24 weeks to 48 weeks, the addition of combination pills, and soon we will have single combination pills that are likely to be available in the next few years. And so in this figure, there's a paper just released by Martin et al., Natasha Martin in Hepatology, where it looks at treatment initiated per 1,000 people who inject drugs. And basically, you can project that if you can scale up therapy within the next few years, you would be able to deliver these kinds of therapeutics to use for treatment as prevention. And the notion here is that a viral cure means no transmission. And so whether you take the perspective of the social network or you take the molecular fingerprint that can track the transmission events between high-risk populations, and if we focus our efforts on core transmitters, you will be able to make a dent in the ongoing onward transmission of hepatitis C. And here, what Natasha has done was to look at the relative prevalence reduction at 15 years, based on the prevalence in Edinburgh, which is 25%, Melbourne, 50%, sadly in Vancouver, 65%, based on no scale-up to a scale-up to 80 individuals per 1,000 treated annually. And you can see that it's more effective when the rates, your prevalence rates are lower, harder to treat when your prevalence rates are higher. Nonetheless, they have also modeled the necessary scale-up in annual treatments per 1,000 to achieve a 1/4, 1/2, and 3/4 prevalence reduction in 15 years. And again, the jurisdictions like ours will have to work harder to make a dent in the epidemic. So finally, hepatitis C, and you've already heard, is a disease of the vulnerable. People who inject drugs, men who have sex with men, street workers, Aboriginal populations, people who are incarcerated, immigrants and refugees, many of whom were infected in their country of origin. We strongly support using the CDC's recommendation of a syndemics approach, which is essentially using a public health lens. It is about understanding the social and contextual factors that foster disease in certain populations and using that knowledge to drive policy and programs. If you think about treatments in two perspectives, if you think about the baby boomers here, it's about increasing the treatment uptake because it's shown that SVRs reduces viral-related morbidity and mortality. So you need the testing, the seeking, the engagement into care, the prioritization for those who are at greatest risk in the near term, retention and care because the comorbid conditions like alcohol also need to be stemmed. And at the same time, we have to think long-term in terms of prevention, and because Hep C infection is a surrogate for acquisition risks, and the years of potential life lost, as you know, are very high, we need multifaceted harm reduction and retention and care strategies. and treatment as prevention to reduce transmission. So finally, I'll end with two Canadian physicians. One is Norman Bethune. There is a rich man's tuberculosis and a poor man's tuberculosis. The rich man recovers and the poor man dies. Doctors should go to the people, and of course, as a physician, he would say that. But we've already heard a few days ago that it's important for primary care to go to the people, and it doesn't have to be delivered through doctors. William Osler says, medical care must be provided with the utmost efficiency. To do less is a disservice to those we treat and an injustice to those we might have treated. We need to make the impossible possible. Thank you.